Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Today, we'll talk about one of the most common and serious heart valve problems, aortic stenosis, with my guest, cardiologist Ankur Kalra. He's the Division Chief of Cardiology at Upstate. Welcome back to the Informed Patient, Dr. Kalra.
Thanks for having me back, Amber. It's a pleasure to speak with you.
Aortic stenosis is when the aortic valve narrows between the left ventricle and the aorta. What causes this?
You explained it well. It's one of the most common valve conditions that we see as heart doctors. It's congruent with human aging, although we are learning mechanisms, novel mechanisms for why aortic valve becomes calcified in a subset of patients versus we see several 80 and 90-year-olds where the aortic valve is not stenosed. So I would say it's a function of aging. It's a function of human aging. I think aging aside, there are other contributors to accelerated stenosis or calcification of the aortic valve. We can get into the weeds of what I think some of the risk factors may be. But I think suffice it to say that just like coronary disease or heart disease, as we call it simplistically, when we refer to heart disease, what a doctor is generally referring to is plaque buildup in the arteries that run on the surface of the heart. So akin to heart disease being a function of age and age being a risk factor for heart disease, age is also a risk factor for aortic stenosis or aortic valve disease.
Do you see it equally in men and women?
I think the awareness that it affects men and women alike, is lacking. We've known now through published literature that women do not seek timely care for heart-related or even other health-related issues, and aortic valve disease is no different. I think biologically or epidemiologically, it affects men and women alike. So that's an important question because it brings to the fore the disparities that exist, which are a function of gender, which, should not exist, in my opinion.
Now, I know rheumatic fever has been tied to aortic stenosis, right? Do you see that often?
So this is a very good question. I think it also is a question which is relevant to Central New York, because as a cardiologist practicing in the US, and I've practiced at different locations, I trained in the Northeast and went for advanced training in the South in Texas. Then I practiced in Ohio for 5 years and Indiana for 3 years. The amount of rheumatic valve disease that I've seen in Central New York reminds me of the time I spent when I was a medical student in India. This is, more than 2 decades ago. And for some reason, I think because we have access to the North Country and we have an indigent population, we see a lot of, in our practice here at Upstate, we are seeing a lot of rheumatic valve disease. To answer your question, so this was a preamble to the answer to your question. To answer your question, rheumatism or rheumatic fever definitely can impact the aortic valve. The most common valve that it impacts is the mitral valve, but it also can affect the aortic valve. That rheumatic involvement of the aortic valve or the mitral valve is very different than what we call as senile calcific aortic valve stenosis, which is, like I discussed before, a function of the human aging, where it's senility leading to calcification of the aortic valve and the valve not opening as well as it should. A good analogy that I give to patients is that it's sort of like a hinge of a door, which has become rusty over time. And because it's a rusty hinge, the solution is anatomic, and that is replacing the hinge, so replacing the valve. Now, how you replace the valve has become completely different in 2026 compared with, say, what it was, 15 years ago.
I definitely want to ask you a lot more about that, but let me ask about predicting which people may develop aortic stenosis. If someone has a history of rheumatic fever, does that increase their risk?
So certainly a history of rheumatic fever will increase the risk of you having rheumatic heart disease. Rheumatic heart disease is different from acute rheumatic fever. Acute rheumatic fever will occur like any other febrile illness, usually affects children. I think a good point of history taking is, do you ever remember being on weekly shots of penicillin as a kid? That is the acute aspect of rheumatic fever. And then its long-term sequela occurs several decades later when it presents as rheumatic heart disease, when the valves, after they've healed from the acute infection, are now just fibrosed or thickened or less mobile compared with when they were before, when they were, healthy valves. So that becomes an important aspect.
Let me ask you if there's anything we can do to prevent aortic stenosis, or is it all sort of the general advice we hear about preventing heart disease in general?
So general advice that we hear in preventing heart disease, because the form of aortic stenosis that we see very commonly in our patients has the same risk factors that heart disease has. So we cannot do anything about the fact that all of us are aging. However, we can control the risk factors which we know are associated with quote unquote heart disease. And that is, high blood pressure, so hypertension, diabetes, high cholesterol. Those are risk factors even for aortic valve disease. There is a genetically determined marker of atherosclerosis, which is LP(a) or lipoprotein(a), which is getting a lot of media these days. Rightfully so, because we've known through epidemiology that it is one of an important predictors of acute events, which are heart related. And well, it turns out that LP(a) also has a role to play in the pathogenesis or in the development of aortic valve stenosis. So I think if you take good care of blood pressure, if you manage diabetes appropriately, if you have diabetes, that is, and if you take care of your lipids, either by medical intervention like taking a medication or just by lifestyle, which is eating properly. When I say properly, what do I mean? Diet rich in fruits, vegetables, whole grains, legumes, nuts, extra virgin olive oil, tea, coffee, water is the best beverage. And, based on how quickly I said that, it's sort of autopilot for me when I say this to patients in clinic. I think these are important risk modifiers, for lack of a better word, to optimize your risk for future events, whether it's related to plaque buildup in the heart arteries or whether it's aortic stenosis.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with Upstate Cardiology Chief Dr. Ankur Kalra about aortic stenosis. What are the symptoms of aortic stenosis? How would someone find out or know that they have this condition?
So the symptoms, the most commonly described triad in the literature is chest pain, passing out, and shortness of breath. And it may start off as chest pain, but then progress to you passing out following heavy physical exertion. And then you start having progressive shortness of breath. So exertional intolerance, whether it's related to shortness of breath or chest pain, is something that is a key symptom or symptoms of aortic valve disease or heart valve disease. And again, these symptoms are more so shortness of breath than chest pain, but shortness of breath can also be a presenting symptom for plaque leading to a blockage in a blood vessel that runs on the surface of the heart. So the symptom complex is very similar to, it being quote unquote a plumbing problem or a door and a hinge problem. The plumbing problem being plaque buildup in the arteries that run on the surface of the heart, and the door and the hinge problem being a valve problem. But those are the most common symptoms.
And you could have both of those things happening at the same time, right?
Yes, 50% of patients who have severe aortic valve stenosis also have a blockage in the blood vessel that runs on the surface of the heart. So when we are preparing them for a valve replacement as part of our diagnostic algorithm, all of these patients get imaging to image the blood vessels that are running on the surface of the heart to make sure they have no significant blockages.
Is the imaging how you diagnose this? I mean, I know you talk to the patient and you listen to their symptoms, but do you need imaging to confirm it?
Yes. So when we see these patients, when we evaluate these patients, we listen to their heart. the murmur of aortic valve stenosis is very classic. We call it a diamond-shaped murmur or a crescendo decrescendo murmur. So you will hear a murmur as you are putting your stethoscope on the patient's chest to listen to the heart. And then we get imaging. So we get a transthoracic echocardiogram, which is an ultrasound of the heart. In vast majority of patients, a good transthoracic echocardiogram or ultrasound of the heart will very reliably and with high fidelity diagnose aortic valve stenosis. And once that diagnosis is established, we have to discuss about treatment modalities as to how to treat aortic valve disease or treat the severity of calcification on the aortic valve. And, like I mentioned before, it's an anatomical problem that requires an anatomical solution. The solution is replacing the heart valve.
So what happens if aortic stenosis goes undetected and untreated? It's not going to get better on its own, right?
No. So it's a question that patients ask because a lot of these patients are in their mid 80s, upper 80s, sometimes 90s, and they're accompanied by their family members. And so the family members ask, well, what if we do not do anything? And I tell them the chances are that your loved one will survive the next 1 year is 50%. The chances are that your loved one will survive in the next 2 years is 20%. So it's tied to deaths. There's also an increase in the incidence of stroke. There's also an increase in the incidence of heart failure. So these patients can get hospitalized for heart failure if they're not treated in a timely manner. So heart failure, stroke, and death are the big three sequela or manifestations or outcomes of an untreated aortic valve stenosis, severe aortic valve stenosis.
If a person has aortic stenosis, does that predict anything about the other valves in the heart? Would they similarly be calcified necessarily or not?
They can be. I mean, aortic stenosis has an association with another common condition that we see as cardiologists, and that is calcification involving the mitral valve. So mitral annular calcification is another very commonly encountered problem that we see alongside aortic valve stenosis.
Let's talk about the current advice and the options for someone who's found to have aortic stenosis. It sounds like it's somewhat of an emergency, really, to have this repaired, right?
Yes. So once it's calcified and once it's severely stenosed, hence the word aortic stenosis, it's not a repairable valve. It has to be replaced. The question is, how do we replace it? Now, like I mentioned earlier, up until about 15 or maybe 2 decades ago, the only modality to replacing it was surgical aortic valve replacement. So you would have to be put on a heart-lung machine, the bypass machine for circulation, and the heart would be in a standstill, and the surgeon will, crack your breastbone and access the heart and replace the valve, calcified diseased valve, with a new valve, either a bioprosthetic valve or a mechanical valve, depending on how young or old you are. Now that has changed. The most common modality across all patients for replacing an aortic valve is not surgery anymore. It's transcatheter aortic valve replacement, which is we use wires and catheters to go all the way up to the patient's heart through one of their arteries in the leg. And we put a new valve inside their old valve. And the old valve is crushed and the leaflets are splayed open and the new valve sits in the old valve. And, there are different valves which are approved for this modality of treatment. There is a balloon expandable valve and there is a self-expanding valve. And each have advantages and disadvantages and, complication rates. And we go over those complication rates with patients when we are describing this procedure to them in clinic.
So this avoids cutting their chest open.
Mm-hmm. This avoids cutting their chest open. As a matter of fact, we started after I got here in the summer of 2025. We've started a same-day discharge program where select patients who we think are safe for same-day discharge have come to the hospital from home in the morning of the procedure, gotten a new valve, and were released or discharged back to home that same evening. More than 90% of our patients, I want to say upwards of 95% of our patients, go home the next day.
Wow. Now, I thought there was a difference between a mechanical valve and a tissue valve. Do they still come that way? Are there options like that?
Yes. So surgically, you're right. You have a mechanical valve, which is a metallic valve, and then you have a bioprosthetic valve, which is a tissue valve. The tissue could be bovine or porcine, which is either cow or pig. The valves, the transcatheter heart valves that we use are, we say hybrid valves. They've got a framework, which is metallic. It's usually an alloy of nickel and titanium. It's called nitinol. And then the leaflets are bovine or porcine, so cow or pig leaflets.
Let me ask you, the leaflets, that's how the valve moves.
Mm-hmm. The leaflets is the component. The leaflets are essentially how the valve opens and closes. But the leaflets need to be mounted onto a structure which can hold the leaflets together. And that structure is nitinol. That's an alloy of nickel and titanium.
Now, as you're replacing the valve through the catheter, how do you see what's in front of you?
I'm not sure if I exactly understand your question, but I'm going to try to answer it to the best that I can. So before we subject these patients to valve replacement with a transcatheter technique, we image the vessels in their legs because we want to make sure that the vessels are big enough for us to accommodate our equipment safely without injuring those vessels. And then we spend a lot of time imaging the heart valve itself. So we get measurements of the degree of calcium that is deposited on the heart valve. We get the size of the heart valve. We get the size of the annulus, which is where the heart valve sits. We measure the height of the heart arteries to, where they originate from, because we don't want to obstruct the heart arteries and their origin in the aorta by putting a new valve inside the old valve. So we do a series of intricate, technically savvy measurements, for lack of a better word, where we are defining the anatomy of the valve in great detail. Once we go in with wires and catheters and we have a valve mounted onto a wire and a balloon, if it's a balloon expandable valve, or to a platform, if it's a self-expanding platform, then we know where to start deploying that valve. And we use a marker to mark the nadir of the native valve, because we want to deploy it inside the old valve, not too deep inside the left ventricle, because that will cause problems. The valve can embolize into the left ventricle. Or if it's deployed too high, the valve can embolize into the aorta. So we are looking for the sweet spot where we can safely deploy that valve, using the calcium of the old valve as a friend, because that will be the anchor of the new valve and will anchor it in place. We use a series of images and angulations and measurements to come up with the best deployment view and the best deployment height and the best deployment depth, so that we're not obstructing the origin of the heart arteries, and we are giving the new valve the maximum chance of functioning properly and lasting for as long as it should last for.
So it's very precisely placed, it sounds like.
It is very precise. The preparation that goes into getting someone a transcatheter heart valve is very nuanced and very detail oriented. And that's why the procedure time is, my average is less than an hour. So most experienced operators, the average would be less than an hour. It is less than an hour because a lot has gone into the preparation. So it's sort of like a very focused, sort of like a SWAT operation. You're sort of going in knowing exactly what needs to be done. And then you're coming out with the desired outcome in mind. But you can do that or orchestrate all of that in the OR, because a lot goes into the preparation of getting these patients prepped for getting them a transcatheter heart valve.
Now, is the heart beating while you're doing this procedure?
The heart is beating when we are doing this procedure. The heart is the only time in a self-expanding platform, it's beating all the time. In a balloon expandable platform, we pace the heart at 180 beats per minute, because when you pace the heart that fast, there's a temporary standstill, which gives you enough time. It just takes seconds to get the new valve in. And that is enough for us to adequately deploy the new valve. The standstill is a few seconds, so that is enough time for us to deploy the valve.
How do you make sure that the valve stays where you want it to stay?
It's the calcium. The calcium becomes a friend. It anchors the valve. The only thing we need to do is we need to make sure that we're nailing the depth of how deep we want the valve to be.
You're listening to Upstate's The Informed Patient podcast with your host, Amber Smith. My guest is Upstate Cardiology Chief Dr. Ankur Kalra, and our topic is aortic stenosis. So let me ask you to tell us what you tell your patients in terms of what to expect from a replacement like this. Are there things they have to do ahead of time to get ready for the procedure?
So most patients, when I see them in clinic, they are anxious to get the valve replaced, because at that time, by the time they come to see me, they are symptomatic and they've been diagnosed with severe valve disease. Number one is reassurance. It can be nerve-wracking to think that they will be in the OR on the operating room table getting a new valve. Many of them love the idea of going home the same day or the next day. I can tell you that almost all of them are reluctant to get the chest cracked, so they are reluctant to get surgical aortic valves. I still make sure that they understand that at the end of the day, it's still a valve replacement procedure, so it is a major intervention, even though it's done minimally invasively. I go over the procedure with them, just like I did with you, and I tell them about anticipated complications. Now, as years have progressed and years have gone by and the technology has improved and there are newer iterations of valve and catheters and wires in the market, and we've understood how we deploy the valves better and better, we have tried to minimize the complications. They still exist. So I tell them that, the three big complications are risk of stroke, which also exists in a surgical aortic valve replacement procedure. The risk that I quote to patients is anywhere between 1% to 2%. Depending on what valve we use, either a balloon expandable valve or a self-expanding valve, there is a risk of getting a permanent pacemaker. So from 3 to 7% to up to 15% is the risk of getting a permanent pacemaker. And then you have bleeding and vascular complications. And that's why it's crucial that we image the legs and size the vessels before we go in with the equipment to deliver a new valve.
Are there any restrictions during the recovery phase?
So during the recovery phase, the only restriction would be not lifting anything heavier than 10 or 20 pounds, maybe for about a week. And that too is not an evidence-based recommendation. It's something that we surmise. We just want to make sure that the arteriotomy site, the site where we access the artery to go all the way up to the heart, we suture it at the end of the case, make sure that it's closed, and we take an image, make sure that there's no leak. But we still want patients to give the injury adequate time for healing before we access it again.
Is a replacement like this meant to last a lifetime?
The answer is yes. It's meant to last a lifetime. We've been doing this for a while, so we now are seeing more and more cases of transcatheter heart valve failures. So the valve will fail in anywhere between 7 years to 10 years. The outcome data, the durability data so far looks really, really good though. So, we want to say that these valves last at least a decade, if not longer. But the idea to give a valve to someone is for it to last a lifetime.
Do the patients continue to see you for follow-up after the surgery, or do they go back to primary care, or how does that work?
So mostly I would like to see them back in the office for one time at least, after about a week or within a couple of weeks of the procedure, make sure they're doing well, that symptoms have gone. Most patients will tell me right away that they feel completely different. They feel they can breathe. immediately. So that's even before they are released after they've gotten a new valve. But I still like to see them back in clinic for, at least once before for releasing them to their referring cardiologist. So I do see them at least once.
Are there things that have to be monitored to make sure that the valve is still working, or how would they know if the valve wasn't still working?
So what we do is we get an echocardiogram immediately after the valve is deployed. Then we get another one at 30 days. Then we repeat one at 6 months and then a year. That is one aspect of monitoring. It's become the norm because all these cases are submitted to a national registry. Medicare mandates that for all sites to do that because they want to collect longitudinal follow-up data on all the valve cases. And then it becomes a good repository for future research. That's how Medicare pays for these procedures. Aside getting these serial ultrasounds at the intervals that I just mentioned, I think we simply go by patient symptoms. So they'll tell us that they're not short of breath anymore, and they don't feel dizzy or lightheaded anymore, or they're not passing out, or they don't have chest pain anymore. So that is, along with what you see on the echocardiogram, is a really good assessment tool after you've put a new valve in.
Do you see anything on the horizon to look forward to related to treatment of aortic stenosis?
Yes. So, some have argued that we are essentially treating one disease with another disease because we are giving them a prosthetic aortic valve, which we know by the sheer nature of the fact that it's made of tissue, it will degenerate over time. So we are sort of treating one disease with the other disease by giving them a prosthetic device. And some have argued that, what if you were to deploy a valve which, over time gets absorbed or evaporates and just the leaflets remain so that it's more durable. So that I think is an interesting aspect to look forward to in the management of patients with aortic valve disease. The other aspect is once we have therapies for targeting a lipoprotein little a or LP little a, I think that'll be interesting to study what happens to patients with both native and prosthetic aortic valve stenosis, right? So native is your own valve, prosthetic is once you have a transcatheter valve or a surgical valve, it's now becoming stenosed. Whether these medications can either halt the progression or sort of lead to a decline in the progression of prosthetic or native aortic valve stenosis by targeting lipoprotein little a. So I think those are the two aspects that I'm looking forward to in terms of managing patients with aortic stenosis.
Well, it sounds like an exciting field with some more advances heading our way, hopefully.
Yes, it's been regarded as one of the most transformative inventions in all of medicine. Transcatheter aortic valve replacement. I mean, aspirin was one of them. Thrombolytics, blood busters was the other one. The transcatheter aortic valve replacement is right up there with penicillin and invention of antimalarials and tuberculosis, and this is right up there. So, yeah.
Well, Dr. Kalra, thank you so much for taking time to tell us about it.
Yeah, no, it's my pleasure. It's a field of both clinical interest and research interest, and I'm happy to be with you to talk about it.
My guest has been Dr. Ankur Kalra, the Division Chief of Cardiology at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.